And in a squamous patient, Tracey, do you? I mean, you know, we in that small percentage that are going to get Pembro, high expressors. Once they progress on Pembro, are you back to your usual paradigm in that population of patients?
Right. And as far as line of therapy, I don't think that that's a very useful concept right now, especially when we're changing modalities. I think it probably doesn't make as much sense to follow up with second-line immunotherapy if you use first-line immunotherapy. But in terms of if I use first-line immunotherapy and they progress, then I'll just start over with cytotoxic chemotherapy and use a platinum-based doublet, and that's not a problem.
We're starting to see some clinical trial designs of later line, early stage immunotherapy that require PD-1 or PD-L1 refractoriness, and I think these are stacking up a little more in squamous actually. So where trials are available, the PD-1 or PD-L1 progressor may have options other than chemo if they're considering
Right,
trials.
but those are clinical trials,
Absolutely.
and my expectation would be that they are a little bit behind the 8 ball in their likelihood of having a response to the additional same concept therapy, whereas chemotherapy for them is a clean slate.
It's totally new. Yeah, to an extent, I guess all of, most, not all, but most of the agents that hit our sort of top 10 list of things being studied are T-cell stimulatory agents, with 1 or 2 exceptions.
So,
But I don't know if we're going to see the same drop. Like in cytotoxic chemotherapy, you clearly see a drop-off in efficacy. It doesn't matter what you give first line, the efficacy is roughly similar, and it doesn't matter what you give second line, the efficacy is roughly just as bad. And I would expect that would happen with immunotherapy, but I could be wrong. We actually have RADVAX studies going on in our institution where you're trying to potentiate the immunotherapy that they already had by radiating a piece of their tumor and seeing if you can cause an antigen release to increase the immune response. Hopefully it'll work.
so I know this is going to be hard for all of you, but I want you to go back before the immunotsunami occurred, okay? And get back to the drug that Ed brought up, and that's ramucirumab. Antiangiogenic antibodies were a no-no in squamous because of the risk of bleeding. That experience with bevacizumab we had, that was not the experience with ramucirumab. I think one of the, the REVEL trial we've talked about, I'm going to have you discuss it in a second, get your opinion on the addition of ramucirumab to docetaxel. But, I think what happened before RAM could have any traction in the community, I think that was approved in December of 2014. And then, nivolumab with that very positive trial occurred 3 months later, and it kind of got swallowed up in that and never had time for traction. If the immunotsunami never happened, where do you think ramucirumab would be here? We know you're not a fan of docetaxel, but let's face it, for a long time, docetaxel is the only choice we had in the second line setting, right? Approved choice.
So I think if you were to play the thought experiment and go back, let's say at least a decade, if that trial had come out, I think it would have been received very favorably, and we wouldn't be speaking in the way we're speaking of it. Because as was pointed out earlier, for a while, squamous was the desert, right? Where you really, we were not empowered to really help these patients the way we are today.
And specifically, antiangiogenic therapy was a no-no.
Was a big no-no. In the phase 2, I think it was about a 1/3 rate of fatal hemoptysis.
4 of 13.
I'm sorry?
4 of 13.
Well, that's about a third.
Yes. No,
yeah.
Life-threatening or fatal.
And I witnessed one of these. In training, I witnessed a patient who on repeat pathologic review was found to have a mixed squamous adenocarcinoma, but who was read out initially as purely adeno, did get bevacizumab, and he and I were playing chess when he hemoptysized his entire blood volume. It's one of those things you never forget. For those who lived through this early experience, it's something you never forget. So I think there was a culture against these agents in that class in squamous, but that's not what we've seen with ramucirumab. This agent does appear to be safe in squamous patients. The randomized trial was well conducted. It was conducted ethically. The data, as best we know, was conducted well. It has all the right stopgaps. And I think the question for practitioners is just, are you using docetaxel to add it? If you are, it does add something, albeit small. And then the value question that we were just discussing, whether it reaches that threshold to be worth using.
Yeah.
But it is a legitimate agent.
Yeah, and it reminds me, we talked about nesituzumab before and the magnitude of that benefit. These were very similar clinical trial outcomes, right? I mean, Ramu did have the triple threat, response rate, PFS, and OS. So it had that advantage to it, but the magnitude of each one of those actually was very similar to actually, the overall survival very similar to nesitubimab, and so that would be an issue. Is it your go-to treatment if let's say the patient has a significant autoimmune history? Is that your second line choice if you can't give an immunotherapy?
I mean, I can tell you, we had that combination, and we still do, on our pathways prior to the IO tsunami, as you describe it. And we were using it quite frequently as our second line default in squamous, in patients with squamous cell. Not only was the side effect profile very favorable compared to bevacizumab, in the non-squamous side, they even showed responses post previous bevacizumab. Yeah. So, there were a lot of differences between that drug and Bev, and you didn't feel as, you didn't take pause in writing for it. It was, and to me, if I could get 2 or 3 cycles of the combo and then continue someone on maintenance, this way I didn't have to give them 4, 5, 6, cycles of docetaxel, that was a win. Yeah. And so we used it actually quite a bit until Nivo was approved, and then that changed everything.
When you used it, were you giving your docetaxel at 75, the standard dose? Yeah. I mean, you dose reduce if you needed to, but it was very well tolerated, and it really didn't feel like you were adding much at all. You didn't watch for blood pressure or for renal insufficiency or all these things. It was very well tolerated.
I was always nervous about it because in the eligibility for the actual study, it says that they excluded central tumors that involve the central airway and the vasculature. I'm not always sure. I look at my own scans, but I'm not always sure what that means, and I'm still nervous about using a drug like that in squamous.
Well, if you actually read in the publication by Eddie Guerin, and you read the patient selection or whatever they call it in there, I mean, there's a long list of things that people were kicked out for, and I'm reading this going, oh my God, I mean, if they step to this, there were a lot of exclusion.
It doesn't seem like your typical squamous cell that you could just throw on there.
Careful to not hurt people.
And the one guy I gave it to, terrible asthenia, terrible stomatitis, which does increase with the combination.
Yes, it does.
So, and then there was Nivo.